Good morning. Good afternoon, I meant.
Afternoon.
Why don't we begin without further ado? So let me briefly introduce the first paper. It's analysis and projections of family households, living arrangements, and home-based care needs for disabled older adults in Sri Lanka. So the presenter is Dr. Zhenglian Wang, who is a senior research scientist from the Center for Population Health and Aging at Duke University in the US. So please begin, Dr. Wang. 15 minutes, please.
Thank you very much, Professor Park. Okay. My presentation is based on our study of Sri Lanka census data and survey data. And based on this data, we do the projections of family, households, and elderly living arrangement and home-based care needs for disabled old elders. And today I'm going to present the 5 parts. And first of all, I'm going to introduce the methodology and the data source, and then give you the results of analysis on Sri Lanka 2012 census data, and the results of projections of households, living arrangement, and home-based care needs for disabled old adults in Sri Lanka from 2012 to 2016. And finally, I'm going to give you the discussions and policy recommendations. In this study for Sri Lanka, we applied Profami extended cohort component method software and the conventional census and demographic service data. And there's a lot of methods for doing the households and populations projections. And for this study, we choose Profami model. And it does much better than traditional headship race method for household and living arrangement projections. This method can project very detailed household and elderly living arrangements and the population by age 6 distributions simultaneously. Actually, this method software can be used for many applications related with households. For example, and there's applications was employed for the US household energy consumptions, and also the United States housing projections at the national and the subnational levels, and also the applications for vehicles consumptions for Austria and United States. And recently, there's also application applied for the household finance projections in China by Dr. Zhu in 2020. For applying Profami model, there's three parts of data needed. And the first data set is base population. Like other kind of population projections, we need the starting point population. And in addition, for the normal projections variables of sex, age, and for doing household, we need the more variables such as marital union status and the relationship to the householder and whether the household, either the individuals living in private or institutional households. This kind of variables is very common and easy to get from census macro data. In this presented study, we get these variables from Sri Lanka 2012 census macro data.
Sorry, Dr. Wang, can you speed up a little? You only have about 10 minutes left. Thank you.
Okay, thank you. Yeah, and in addition for the macro data, we also need 100% tabulations in order for the projections dealing with entire population rather than the sample data. The second part is demography rates. For the demography rates, we need mortality, fertility, marital status transitions, children leaving home, and migrations. And for this study, we got the mortality from left table and first major rate and fertility rates by parity, we estimate from the DHS survey data. And the third part of data is summary measures. And these summary measures for you to tell the model and how the demography changed over time. So you need to give how high is fertility or mortality and migration and so on. So fertility, we need to give the total fertility rates. Mortality, we define by life expectancy at birth, for instance. And all these kind of some measures you also can get from the conventional data. For example, Virginia rates of marriage and divorce, for Sri Lanka data, we got from voter statistics. For example, we know in 2012 how many marriages and divorces occurred in the year, and also we know the population by marital status so that we can easily to calculate this the rates of marriage and divorce. And this figure shows you how the model deals with marital state transition rates. This is 7 marital model, and in addition of marital status is considering the cohabitation. For our Sri Lanka study, and because cohabiting not popular and the data is not available, so we only do the full marital status transitions. And now we look at how many households the farming can produce. And there are 40 types of households and categorized by generations. And each generations, you can have the households based on the different person's gender, marital status, and household size. For example, for one person only household, you can know how many one person is male, how many one person is females, and what's the marital status as they are, what is their age. I think this kind of information is important for agent study, because for the elderly who living alone need more attention and they need more care for the community. And here is the summary result of analysis of Sri Lanka households in the year 2012. So we can see here the majority of household is 2 generation, is about 60%, and one generation household is about 20%, and they still have almost 19% of 3-generation households. And this is household size distributions. In average, the household size is 3.73 in 2012. And the highest percentage of household size is 4%. And still, and there's 7.2%, 1% only households. And for this is a result of living arrangement. So we can see there's a clear, quite a differential between genders. And yeah, you see, for example, for living alone and in the younger age groups, there's a much higher percentage females living alone, is 8%. In comparison, male, there's almost there's a 2.9%. It's much higher. And for the older groups, is the same pattern. And the female is 6.5%, and the male is 3.9%. For living with children and not married, and the females have much more percent than the males. And the males, they enjoy it more with, you know, they have more percentage of married and with children. Here is our analysis of the percentage of disabled adults by gender, age groups, and marital status. So we can see that people, the elderly who are not married, there is a much higher percentage than they are married. The left side is for elderly, they are not living with children, and the blue line is for the males. And the double line is not married, and the solid line is married. So we can see, and the males, they don't have the spouse live together and have a much more percentage being disabled than the male who are married. And the same pattern we found for the females as well. But the difference for the males is much larger than females. And we also observed that for the old sort, for the females, the differential between the married and non-married become much larger than the younger adult. And this pattern we also can find for the living with children. And also, no matter married or not married, we found the females' disability, the proportion of disability is much higher than males. Okay, because we study the studies based on the analysis of sensor data and survey data, and we use power farming model and to do the projections of future elderly living arrangement and households. So here is a summary measures we used for the study. And we assume the total fertility rate is going down, and the mortality is going down, and the genital marriage rate is going down as well, and the divorce rate is going up. And
one more minute, Dr. Wan. Please wrap up.
Oh, I'm so sorry. Okay. And here, this is the results of based on the census data and the projections of number of disabled elderly. So we can see that the number of disabled will increase dramatically, especially for the oldest old. So the red line is also old, the relative increase. So we can see it's 5 times the increase in the 2060. And we also did the sensitive analysis, and we do the 3 scenarios for the middle, low, and high, and we want to see if only the disability rate change, how effect to the future disability population. So we can see the red line is a high disability rate, the yellow line is low. So we can see that the difference is quite large. For example, if the disability rate is going up, that will be 3.57 million, and if you're going down in 60, it's 1.65 million. Okay, so our analysis shows that the female older adults have significant disadvantage in disability status as compared with male counterparts. And this study shows that changes in older adult disability status are the most important determinants of home-based care needs for disabled older adults in Sri Lanka. Our analysis also shows that regardless of whether older adults' disability status are assumed to improve or deteriorate over time, the home-based needs for older adults in Sri Lanka will increase substantially.
Dr. Wang, please conclude your presentation.
Okay. Yeah, so our conclusion is also, we suggest to promote older adults live together with children or nearby, and in order to improve the adult the disability status. Thank you.
Thank you very much, Dr. Wang. Dr. Wang's paper will be discussed by Dr. Gretchen Donauer from UC Berkeley. Gretchen.
Hi, thank you very much. I thought this paper had a fascinating approach, and I am a big fan of household projections. I think they give such rich outcomes. It's really a fascinating area of study. And it's also, I can see a tremendous amount of work that these kinds of big projections with so many pieces are just a data hungry beast. So I appreciate how much time the authors had to spend on getting all of the data and all of the inputs. I have a couple of, overall, I was a little confused about the approach of, I think, using of the data care needs, whether it seemed that you were having projections of people who had a disability that came from the data set, that you had indicators of how many people said that they had difficulties with certain activities, but then that it was also weighted by the household structure, as though the household structure in living with, say, adult children was being used to indicate that these are people who need more care, so that there were disabled persons who maybe needed less care and who were seen to be living alone, and then disabled persons who maybe were living with other family members or other household members and so needed more care. I think if that's the approach, the one concern I have about that is other research that I'm involved in that shows, especially for older women, who is a very important population that you're looking at in this work, that they're very often care providers, so that they're taking care of a spouse or they're taking care of grandchildren, so that adult children can maximize labor force participation. So if we are looking at sort of co-residence as an indicator of needing care, that we should be careful with an approach like that. And I know that Sri Lanka, I think, has a time use study. It's a small scale, preliminary perhaps, but that could at least be another data source that you might look at to see sort of persons in which particular age groups, how much care they are providing, how much time they're spending in childcare or in care for a spouse or in housework activities. That could sort of make the picture a little more clear that older persons, even if they have certain limitations, may also be providing care while they're, or not just consuming it. And then the other question, I just thought it might be an interesting thing to add just in the descriptive part of the paper, where the definition of disability is looking at people who responded that certain activities were difficult or not possible. Now, those two, and it seems like it's a standard approach to you lump those two responses together and call both of them indicators of disability. But I was just sort of curious as to how many people are saying that something is difficult versus not possible. Because also in aging studies, we know that there are ways to ameliorate difficulties. We can have supportive technology, whether it's very sophisticated or not sophisticated at all, but that really mitigates the impact of the disability on someone's outcomes. So that could be possibly another thing to look at, which then would have some policy implications. And then, yeah, I guess I was just mainly wanting some clarification about the home-based care needs and the role that that was playing in the understanding of the outcomes, how much the disability and the care needs would increase or not. So, but I think that the approach of trying to use household structure to understand how the care economy works is really innovative. And I look forward to seeing how that might go forward. Thank you very much.
Thank you very much, Dr. Donauer, for the concise but clear and constructive comments. Now let's move to the second paper, which is healthy aging and gender gap in India, evidence from longitudinal aging study in India. The presenter is Mr. C.V. Irshad, who is from the Indian Institute of Technology in Chennai, India. The floor is yours, Irshad. 15 minutes,
thank
please.
You, Park. Okay. I think it is visible. May I start now?
Yes, go ahead.
Okay, thank you. Our paper is titled Healthy Aging and Gender Gap in India, Evidence from the Longitudinal Aging Study in India, the first wave. So before I begin, I just want to share a few things. This paper is actually an extension of our recent work, which is related to my PhD thesis, where we actually proposed a new multidimensional healthy aging index for the Indian context. So we don't have any multidimensional healthy aging assessment tool for India. So we proposed a new index for the healthy aging measurement. And this paper, we are actually extending that research to the gender dimension. So we want to see whether there is any inequality, gender-based inequality in healthy aging in India. So that's what we are really trying to explore. So we'll begin. So the background is that we have a combined demographic and epidemiological transition which is taking place, and it has a lot of implications on population health. And we also know that countries like India, it is a developing country, and these transitions, this combined transition of demographic and epidemiological transition, which is taking place at a rapid phase. And as a developing country, there is a shortage of geriatric resources and other policy supplements. So I think even WHO, they're also focusing on healthy aging now. They declared 2021 to 2030 as the decade of healthy aging. So the idea of healthy aging, which is basically an alternative public policy target for all the countries. So I went through the literature. So I found the idea of healthy aging, which was actually coined by James Trice and through his cohort studies in the US context. He followed retired individuals at universities. So he found that there is a possibility of compressing the morbidity duration to a short span of time. So basically we can extend or increase the healthy years of life. So that's what the alternative policy. So that's what this paper is actually trying to focus to basically quantify the healthy aging healthy aging. We also know that life expectancy in all the countries is an increase in expectancy, but at the same time we have now more form of chronic diseases, particularly and in we have studies on. The point is that we have improved the survival, but at the same time we have more health risks. So that's so we have to focus on improving or increasing the healthy of life. So, and we know that in most developing countries, we have a lot of issues with geriatric medicine because these are all very evolving concept in most low and middle income countries. So the basic question that we are interested in this particular study is that historically we know women, female gender category, they are noted for high life expectancy because of some biological and other reasons. But recently there are evidences from very high income countries where the life expectancy gap is actually declining. But overall, we know female gender group, they have higher life expectancy than male older adults. So, but at the same time, we have also evidence that there is a high likelihood of health risk among male older adults than female adults. So the life expectancy is more among female, but their health risk is also higher among female gender group. So in Indian context also, we have evidence that women older adults, they have more health burden than male older adults. So in that context, we are trying to look at the healthy aging and from the gender perspective, what is the gap in healthy aging? So this particular study basically proposes a multi-dimensional healthy aging assessment tool, which actually got published in the Journal of Population Aging last month. So maybe you can read that as well. So here we are extending that particular paper to the gender inequality. So this is the method we have in India now, similar to other harmonized longitudinal studies in other countries. In India, we have the first wave of longitudinal aging study in India, which is the latest one, which was collected in 2017-18. And the first data is available for researchers. It's open actually, so maybe some of you can look at it as well.
Please speed up your presentation. You have until 2:15. Please hit on the key points. Thank you.
Okay. So the survey collected about 72,250 individuals aged 40 years and above. And it was a nationally representative study in India. It collected data from all states and union territories. And this particular study, we considered only individuals aged 60 years and above, which is the 31,400 plus individuals in the LASI. And after dropping some missing information and some...
I think you need to move your slides. Irshad, please move your slides. Yeah.
Okay. Is it coming?
Yes.
Okay. So we basically created, for the measurement of health status, we created a multidimensional healthy aging index, which is where we are considering different domains of health status. It includes physiological, metabolic health, physical capabilities domain, general health status, cognitive functions, and psychological well-being. So it also consists of both subjective and objective health components. And we are creating that healthy aging index in 28 variables, covering all these 5 domains of health status, and we harmonized the total score into a range of 0 to 100. So this is the overall picture. We have 5 major domains under which we have 28 variables. I'm just skipping this part because I think we have limited time. So basically, we have for under each domain, we have a set of variables. We are using those variables to create that healthy aging index. So that's what that's how we measure healthy aging status. So we used exploratory factor analysis for developing this particular index, and the preliminary statistics we have performed, and the data met the minimum standards for doing factor analysis. And we also checked for internal consistency using Cronbach alpha, and it got a higher value, which is acceptable range. Also, we checked the external validity using creating a life satisfaction score. So theoretically, we have evidence that there is a positive association between life satisfaction with better health outcomes. So we created that life satisfaction score, and we got a significant positive relation. So it concludes that our instrument, that is a healthy aging instrument that we proposed, is externally valid and it has internal consistency. So these are the predictor variables that we used in our analysis. We used a set of socio-economic and demographic variables. We have also used health risk behaviors, smoking, alcohol drinking, and physical activities. We have also used frailty related variables, because in literature there are evidence that frailty can be used for predicting health outcomes and even mortality. So we used 3 frailty related variables. We have also used finally government transfers and other assistance to older adults, because people may use these assistance for improving their health status as well. So these are the predictor variables that we have used. So the data analysis, we started with preliminary results, but here I will be showing the multivariate analysis where we have used a quintile regression model.
I think you're still on the wrong slide. Can you move to the correct slide, please?
Oh, I'm moving actually. Data analysis now. Is it visible? Mr. Park, is it coming?
We have what we see is this healthy aging index, HAI, 28 variables.
Oh, okay. I am on 11th slide actually. Network problem maybe, I think.
I think your internet is quite not very good. Can you unshare and we can share it for you?
Okay. Can you share from there?
Yeah, just please unshare the screen and we can share it for you.
Yeah, please unshare.
Okay.
We will try to share. Thank you.
Okay.
Slide 11, early.
Is it coming? Go to 11th slide, 11. Okay, data analysis, stop here. So here for the data analysis, we have used content regression model. We have also estimated the OLS as well. So we estimated at 10th, 25th, 50th, 75th, and 90th percentiles. So the advantage is that if we use content regression, we can understand how the predictors are behaving at different levels of health status. So in the second level, we used content regression based decomposition method, which was proposed by Machado Mehta and later modified by Blaise Melly to explore the gender gap. So we have a lot of equations in our paper. It may take time, so that's why I'm just I think it is better to explain in 2-3 sentences. So the decomposition analysis, where we will be estimating the total gap in health status or in healthy aging index at each percentile, and we will also estimate the contribution of the explained gap and the unexplained gap to the total inequality. So that's what we will be showing in the final graph. Ma'am, move next.
Irshad, we are too much behind time. Can you just please go to your final slide and then just explain the key findings? We really have to finish in 1 minute or 2 minutes. Thank you.
The result you can skip. The result you can skip. Move next. Next. Okay, discussion. What we just go to discussion. Okay. So we found that health status, healthy aging was determined by a set of socio-economic, demographic, health behavior, food security and nutrition related factors, which was consistent with previous studies. We also find that there is a gender gap in healthy aging between male and female. Gender gap is existing, and we found that increased years of age, low social capital, smoking, drinking of alcohol, lack of food security was a health risk predictors, and things like, for example, engagement in physical activity, low frailty, and more years of education was positively associated in healthy aging. Move next. Okay, this is the decomposition analysis result. What I can explain here, the blue line which shows the gender gap, and the x-axis that is the healthy aging index. So at the lower level, that is the blue line, which is at higher, which indicates that the gender gap in health status is higher among the unhealthy individuals, and it declines when we move to healthy individuals. And the green line, which actually represents the discrimination factor, the contribution of discrimination to the total gap. So we find that the discrimination is the main reason that is leading to inequality in healthy aging. Okay, next. Okay, we'll conclude. There is a gender gap in Indian context in healthy aging, and there should be prioritization based on, to reduce the gender gaps. That's all. Thank you.
Thank you so much, Dr. Irshad. Dr. Halima Awang from the Social Wellbeing Research Center in University of Malaysia will discuss. Please keep it to 5 minutes maximum. Thank you. Dr. Halima.
Thank you, Dr. Pa. And thank you, Irshad, for presenting your paper. We all know that the topic healthy aging is of utmost importance when we talk about living longer or having a longer life expectancy. And your study shows the usefulness of micro-level data, such as LASI, to collect information and to analyze such topic on healthy aging. The study involves quantitative analysis, starting with factor analysis in developing the HAI, the Healthy Aging Index. We had used quantile regression Overall, you mentioned that the mean HAI is 81.4%, which is fairly high. However, it would be useful if you mention what is a HAI for male and for female, since there is a gender gap here. So I think that would be useful. The significant factors of HAI, whether they are the protective factors or risk factors, seem to confirm previous studies. And you mentioned in your presentation, in your paper, that separate regressions were run for male and female. However, I did not find it in the paper. Maybe I missed. I'm just wondering as to whether there are differences in terms of the significant factors of healthy aging index between male and female. And you mentioned that a large share of gender gap in health status can be attributed to discrimination factors. I don't exactly, I'm not exactly clear of what the discrimination factors are. If they are unexplained, then I think there is something that can be researched further, because when you say there is gender gap and that it can be attributed to discrimination factors, what are the discrimination factors, if you can explain a bit more. And lastly, my comment is on the HAI development that you based on 28 variables from the seven factors generated from the factor analysis. And you also did mention that WHO actually launched a decade of healthy aging 2021 to 2030. They are currently developing national toolkit for monitoring healthy aging. And I think in their decade for healthy aging, three main components were mentioned: intrinsic capacity, functional ability, and enabling environment, within which there are several items under there. I wonder if you actually had compared your indicators to what is available in WHO. And I think your study provides a good platform to actually monitor healthy aging. I didn't read the decade of healthy aging, in detail, but those were the three components, and within each component there are variables. So I'm just wondering whether you had, you actually had a look at the WHO decade for healthy aging. Thank you very much.
Thank you so much, Dr. Halima. Very good comments. Dr. Irshad, you have 3 minutes to respond to Dr. Halima's comments. Please, the biggest comments only. Thank you.
Okay. I thank Dr. Halima for giving all these comments. Definitely, some of them are very useful for including in in the paper. For example, this healthy aging index by gender for male and female, I will add that. And of course, this separate analysis for male and female, I'm also positively looking. Maybe in future I will do. With regards to the final comment on healthy aging index, the intrinsic capacity, actually I'm just aware of it. When I was reading the WHO report 2015, where it defined these three components. But anyway, I'm very thankful that you brought that to my mind, because I didn't go through that part, but I just gone through the definition. But I think some of the components which I used for constructing the index, it actually also accounts for these three components that the WHO has defined. So maybe going back to the definition, comparing, it may improve the paper. I think so. Thank you.
Thank you very much.
One
go
more
ahead.
thing.
Sorry, go ahead.
Okay. Okay. The discrimination factor, the idea is that the discrimination means if you have same characteristics, for example, male has 10 years of education on average, also have 10 years.
We cannot hear you, Dr. Irshad. So we'll go to Dr.
You have okay.
Irshad.
Okay, sir.
Yeah, please disconnect. We'll get back to you later. We have internet connection issues with you, I think. So we will return to you, but we will go now to Dr. Wang. Okay. Dr. Wang, please respond to Dr. Donhauer's comments. Thank you. Dr. Wang, yeah,
Yes.
go ahead. Yeah, go ahead. 3 minutes. Yeah,
Okay.
thank you.
Yeah. Thank you so much for the comments. And yes, it is true for the woman, and they both provide the caregiver and also to take care for children. But for census for our data, and so far we cannot collect these kind of variables, and we will further do the further search, do the research, and if to see if we can including to see the woman's the role of caregiver and to take care of the grandchildren. And secondly, and for our study, we use this disability status. They use the census question about ADL. Actually, it is like possible whether you can or you cannot. It is true that so there's a difference between difficult and possible. Again, because this data limitation, they only use the census data. So in the future, we will look at other data set to see, and we can do more intensive studies regarding the disability status. Thank you.
Thank you very much, Dr. Wang. So Dr. Irshad, do you want to add anything? You have 1 or 2 more minutes left.
Okay, Park, am I audible now?
Yes, Irshad, we can hear you.
Okay, the last point which I was trying to add was with regards to the question on discrimination. So the discrimination was actually like this. For example, if you have the same entitlements, for example, for male and female, they have equal education, but the discrimination factor actually it can be there if the return to that education level or that entitlement is different for male and female. So that is what attributed to discrimination. So it's mathematically I have provided the evidence in the full paper. So I think by going through that, it will be easy to understand. Thank you.
Thank you, Irshad. Thank you, the 2 speakers and the 2 discussants. We are out of time, so let's move to the next paper. which is a paper on universal health coverage and older persons in Mongolia. The presenter is Dr. Vasuntara Yingpruk-Sawan, a senior research fellow at UNSU Business School in Sydney, Australia. So the floor is yours, Dr. Vasuntara.
Good afternoon, everyone, ladies and gentlemen, and thank you very much for the chat. Can you hear me okay?
Can you please show the full screen? Okay, there you go. Thank you. Go ahead.
Is that okay? Yeah,
Yes.
Thank you. So it's my pleasure to be part of the conference today. So first, I would like to acknowledge that our work is actually the international collaboration between Mongolia, Australia, and the WHO in Geneva. So from our team, the collection of data was done in Mongolia, led by the Mongolian National University Medical Science. I'm a facilitator and did the analysis on behalf of the CIPA in Australia. And we had a technical support using the same standardized data from the World Health Organization, SAGE. And this data has been in 6 countries around the world for people aged 50 years and older. Just briefly about Mongolia. So Mongolia is a lower middle income country of 3.2 million people. It is the second largest landlocked country in the world and one of the most sparsely populated. So it's situated between PRC China and the Russian Federation. So however, approximately half of the total Mongolian population actually lives in the country only large city, the Ulaanbaatar. And because of this rapid urbanization, economic and health inequalities exist. And this is the main thesis of our study. It's not only between rural and urban areas, but also within urban areas as well. And this is between your districts and apartment areas. So unfortunately, because of COVID, I was unable to travel with the team. So these are just to give you a general idea about the disparities happening within the urban area between the girl and the apartment. And these are the traditional living area within the lower income group. Just a few selected indicators. So the urban population, as I mentioned, is almost 70% in Mongolia. The midlife expectancy at birth has increased substantially over the years, but there's still a large gap between males, which is 66 years, and female, which is 74 years. Currently, there's about 7% of Mongolians aged 60 years and older, and within the next 15 years, this number would almost double to 12%. So with regard to causes of death, chronic non-communicable diseases is actually the largest burden of diseases within the country. And this actually, in particular, the very high rates of hypertension. So Mongolia is one of the countries that has made a really significant progress toward UHC, and which cover now over 90% of the population, funded by the general taxation as well as social insurance schemes. So despite having quite a complete UHC, there's still quite a large number of out-of-pocket expenditure, which is still really high, almost 30%, 32% of the total health expenditure. And as I mentioned about geographical area, the delivery of health services is challenged by very large, sparsely populated areas. So there are significant disparities in urban and rural areas in terms of distribution of health facilities, as well as human resources, which are more concentrated in urban areas. So primary health care is commonly delivered by family health centers in urban areas and Zoom health centers in rural areas. So the most tertiary and all other specialized hospitals are actually located in Ulaanbaatar. Public, secondary, and tertiary services can actually be accessed free of charge if referred from primary health care providers, but bypassing to higher services without referrals does result in our pocket expenditure. So this study will look at the patterns and determinants of outpatient and inpatient health services among older people in Mongolia, and we look at the urban and rural differences. The questions we use in the questionnaire for the outpatient is that over the last 12 months, did you receive health care, not including overnight stay in hospital and other healthcare facilities? And for inpatient health services, it's within the 3 years. So the data collection, as I mentioned, was done through Mongolian National University of Medical Science. Mongolian team has done a survey in 17 and 18, and this is face-to-face interviews with structured questionnaires, which is standardized by SAGE data, and also clinical assessments. So the respondents, as mentioned, are mainly from Ulaanbaatar, but we also use 2 rural provinces near the capital as well. The final sample size is 975 people aged 60 years, and they are up to 93. And approximately half are from urban area, which is combination between GER and apartment, and half from rural areas. So the participation rate is 95%, which is quite high, but this is also quite similar to other SAGE Asian countries in India and China. So we report unadjusted crude percentages, but also multivariate logistic regressions with odd ratios and confidence intervals. So the first table, we look at just a description by attributes between rural areas, 478 people, and urban divided by 255 for GER area and 242 in apartment areas. So in summary, compared to rural residents, so both urban GER and urban apartment residents have a greater predominance of having a higher female, having a higher widows, and also having a greater representation of uppermost economic quintile, economic tertile, and also higher education. However, notably, within this urban area, there was also quite a high proportion, very significantly high proportion of people aged 80 years and older, and this could also be related why they have those other attributes. So for health service use, among the 3 areas, so this one have outpatient services. Across the 3 areas, outpatient was highest among the urban apartment areas, 66% of people use service within the 12 months. And this is commonly among both the family health centers and also SUM health centers. About half of people needing inpatient care across the 3 areas, similarly within the 3 years. The 2 other significant indicator is hypertension, which is one that is actually the highest reason for service use. And chronic conditions were higher in urban apartment area compared to others. And I think this could also be mainly because of age. So with regard to accessibility and payment for health services, across both outpatient and inpatient services, travel time over an hour is actually more significantly higher in rural area compared to urban and apartment area. Also, similarly between both inpatient and outpatient services, those in urban residents were more likely to having a free services, meaning they don't have to pay compared to those that are in the rural areas. So these are just briefly the results from multivariate analysis. We have more information in the paper if you are interested. So with this one, we can see that females were actually twice more likely than males to use outpatient services, and also almost 1.27 more than males to use inpatient services. So older persons in lower economic tertiles were less likely to use outpatient services, but actually more likely to use inpatient services. So compared to apartment residents, which is our reference here, GER residents are actually more likely less likely to use outpatient services. Similarly, between outpatient and inpatient services, having an increasing number of chronic conditions are actually strong risk factors. Additional analysis that we did also is to look at whether people pay for services or not. So as I mentioned, even if it's free, but the out-of-pocket expenditure as to prominent and these rural residents were actually 3.65 times more likely to pay for outpatient services compared to the urban apartment residents. So some key points here. So as we mentioned that we found females were more likely than males to use outpatient and inpatient services, and possible explanation is that men were more likely to have a lower rate of awareness, and hence could be a delay in seeking services, especially for less urgent chronic health conditions. So this result also supported by the chronic disease risk factor surveillance study, which also found that females were more likely to report higher prevalence of NCD. Increasing number of chronic conditions, especially comorbidities having more than one condition, were associated with both outpatient and inpatient services. And as I mentioned that hypertension is actually one of the most common conditions. And a recent study in Ulaanbaatar has actually mentioned prevalence of almost 6.5%. So hypertension is also a significant risk factor for heart disease and also stroke. So as we mentioned, the older persons in lower economic tertiles were less likely to use outpatient services, and we think that this could also be due to out-of-pocket expenditure if they could not get to the services that they want to. Compared to urban apartment older residents, there are disparities that we found that low-income rural residents, as well as rural to urban migrants, so these are the ones that live in the rural area, have limited access to higher levels of health services. Higher income individuals, like in the apartment area, they actually were able to bypass the family health centers in urban area and then self-refer to secondary, tertiary care, and hence it's why the out-of-pocket expenditure is still quite high. So our data support other Mongolian household SES data that even though there's free services, but doesn't guarantee the equitable access, and highlighting actually the role of travel, the role of geographical challenges combined by with transport infrastructure. Briefly on the cross-reference to other stage data, so there's advantage in terms of standardized questions, but also the possible international comparisons. So for outpatient services data, roughly around the same, but Mongolia has a really high proportion of older people using inpatient services. It's almost 50% in the 3 years, compared to 22% in PR China and 30% in Russian Federation. Possible explanation could be this high hospital rate is more common in USSR health system, and this could be what we found in this data. Also, there's a preference actually to use inpatient care, and this would be likely due to comprehensive services in the hospitals compared to other outpatient and primary health facilities. Implications and way forwards. So supply interventions, as we mentioned already, that geographical health service inequalities are quite dominant. So there's a number of evidence now to show that the Mongolian state policy on health has now promoted primary health care and home visits, and also promote the use of mobile health screening or mHealth in 21 provinces, also in 9 districts in Ulaanbaatar. So this mHealth would likely to help not only the migrants in the urban area and also the low-income people in rural residents, and also nomadic population in remote areas. Demand intervention is the use of promote the use of primary health care, especially for non-communicable diseases. According to a recent ADB report, the primary health service might not meet the expectation of the user yet, but by expanding the range of quality of services and also referral mechanisms could help to promote this. At this stage, the recent evidence have shown that the family health centers and some health centers already incorporate some health promotion in their routine services. So just a concluding note here, this study contributes to the knowledge of older persons in low and middle income countries, so strengthening this data partnership and harmonized questions for cross-country comparison. There's a future for potential for future follow-up with data, but it's still pending on institutional support and further funding. So hypertension, as mentioned here, is one of the most common reasons for health service use. So promoting the non-communicable diseases prevention and primary care could reduce this cost for hospital-based care. So reorienting health care, though, actually need to expand the services and also be able to attract skilled care professionals in remote area. Self-referrals and mechanism is still going to be quite a challenge, and by improving this would reduce the out-of-pocket expenditure, which is a fundamental challenge really for the universal health coverage. So lastly, as Mongolian population aging would put further demand for health services, and we know these disparities, especially in how outpatient services used for those in the rural and also urban area, and also high inpatient service use, which can be costly. Thank you.
Thank you so much, Dr. Fazuntara, for a high quality analysis and crystal clear presentation. Your presentation will now be discussed by my ADB colleague, Veronica Mendizabal-Joffrey. The floor is yours, Veronica. Thank you.
Thank you very much. And I would like to take this opportunity to congratulate the organizers of the event, which has been really rich in terms of the presentations and discussions. Now, the focus of the conference has been on the role of data to affect policy and programs. And in this sense, the study just presented by Dr. Vasuntara does make an important contribution to address the large data gaps on aging in Mongolia. I have read the paper with quite a lot of interest, and I have a couple of questions and comments. The first one really is a general question, and it refers to the reception of a study on aging in a country such as Mongolia, with a population structure that is still relatively young. The median age in Mongolia is 28 years. So basically, Dr. Vasuntara, what are the challenges in bringing aging as a topic to the policy agenda in such a context, and what is the role of surveys such as the one you have conducted in this process? My next question, somehow related, is on the methodology used and on the resources needed to conduct surveys such as this one in Mongolia. As indicated, you have indicated the survey used a slightly modified version of the questionnaire developed for the WHO study on global aging, SAGE. SAGE is designed as a longitudinal survey, which is costly, requires an institutional support, a structure. So in this sense, what are your next steps on this work in Mongolia? Do you plan to repeat this survey? And what would be the challenges, or what are the challenges in financing this type of work in Mongolia? Now, specifically on the findings of the study, I found that the study achieves its aims and provides very good insights on the patterns and determinants of outpatient and inpatient health service use among older people in Mongolia. I would like to add that the analysis provides also a detailed understanding of health service use, not only in the urban and rural areas, but also at the intersection of the urban-rural, the peri-urban areas that you mentioned, or GARE areas. And this is really where most of the rural migrants settle upon arrival to Ulaanbaatar. I think this was a very strong point in the study because most of the population in Mongolia lives in urban or peri-urban areas, 70% of the total population, and really only 30% is rural. And this rural-urban migration process is just ongoing. I also found that the study brought a multidisciplinary perspective. I found this extremely helpful for our work at ADB. The findings highlight, for example, the role of infrastructure, roads specifically, as well as public transport infrastructure and services in supporting equitable access to health services. Also, when looking at the tables, I noticed that the data collected on mode of transport to medical facilities indicates a high use of public transport among the rural elderly, and you mentioned this during the presentation, but also the urban elderly. Basically, most of the respondents depended on public transport to access medical services, particularly outpatient services. While not indicated in the paper, this led me to think about issues of accessibility and responsiveness of public transport services to the needs of the elderly. And this is an area I think that deserves further study. On the sample, I think the sample affected the results, for example, in terms of travel times to access health services. Your sample for rural areas selected was very close to Ulaanbaatar, the capital city. As such, the time to reach the medical services is likely higher for rural populations in provinces that are farther away from the capital as well as from other urban centers. Also, in terms of the satisfaction levels of the health service users, I found it interesting that the level of dissatisfaction is much higher among urban residents, be it either from peri-urban or from urban areas compared to rural residents. Probably this is linked to higher expectations among urban dwellers, but the paper does not provide further details on this. And on the analysis, while I appreciated the comparisons among rural, urban, and male-female, I would also suggest using an intersectional perspective and analyzing the data, looking at the responses from rural women and rural men and urban women and urban men. This might provide new insights. Finally, this work also recommends reorienting care services towards prevention and primary care management of NCDs as a way to reduce costs from hospital-based care. But the paper does not provide information on the status of prevention service and practices at the moment. So I think this would be interesting for the reader and to provide context. So I would suggest providing an overview to confirm the feasibility of this recommendation. I stop here and thank you for the opportunity to discuss your paper.
Yeah, thank you, Veronica, for the constructive and concrete comments. Let's now move to the second paper before we give Dr. Vasuntara a chance to respond to the comments. The second paper in this session is actually the fourth and final paper in this session is Determinants of Mental Health Deterioration Among Older People During the COVID-19 Pandemic, a longitudinal study in Indonesia. The presenter is Ms. Dinar Dana Karisma from the Ministry of National Development Planning in Indonesia. The floor is yours, Dinar.
Thank you, Dong Hyun.
Sorry, Mr. Dinar. Yeah, go ahead, sorry. Go ahead.
Yeah, that's fine. I believe we met several times. I would like to introduce to all of you too that I will be presenting this paper together with Ibu Wayan from the Survey Meter. So Bappenas and Survey Meter, we work together for in conducting this survey, and we are also writing this paper together. This is still preliminary analysis, so it's not final yet, but of course we are very happy to get your inputs and suggestion. So Ibu Wayan, if you can help to move the slide to the next one. Yeah, so the background question of the study is the COVID-19 pandemic impact on older population. So the pandemic causes several situations that make it unfavorable for the older population, like higher mortality and morbidity among the older population. It requires them to change their routines because of the social isolation. It probably created more health problems because they're changing the way they usually conduct their daily activities. And it also impacts economic activity. So it will, for several groups of older population in Indonesia, it will also be affecting their well-being. So the situation based on several previous studies that we have examined is very prone to creating more health problems toward the older population. And Indonesia is not different and probably even facing similar risks. We are one of the Asian member states that worst affected by the COVID-19. And we just recently experienced the outbreak, even though the situation is now quite good. Due to that situation, the government also implements some type of social restriction, like a quarantine, and we are trying to use that also as a variable in this analysis to see the impact on the older population mental health. Next slide, Ibu Aya. So the objective, as mentioned in the beginning, is to examine the determinants of mental health problems or decline among older people, especially during the COVID-19 pandemic in Indonesia. Next slide. So depression is common in older adults to begin with, even without the pandemic. And a mental health problem that primarily disrupts moods and a depression situation is associated with physical, emotional, and cognitive symptoms and behavioral change. But of course, we are using several standardized methods to see the mental health status of the older people, and Bu Wayan will present about that later. Next slide. So based on some of the literature that we researched, some of the determinants of mental health among the older population during the COVID-19 can be consisting of socio-demographic characteristics such as gender, education status, living location, and specific health profiles, whether or not the older person is healthy or less healthy, level of social interaction, the situation of the economic security, whether or not they're experiencing change in their well-being, as well as whether or not they're experiencing change in access. So we try to include all of these variables into the analysis and see the association between these variables with the possibility of them in experiencing mental health problems or mental health status decline during the pandemic. And we are lucky to have started a pilot of older people information system in 2019, where we collected 14,000 data of older people in 7 villages in Indonesia. And we tried to use the opportunity to create a longitudinal data by following up the respondents during the COVID-19 and ask them and survey them through phone and to update their situation, as well as to ask new questions related to their well-being during the COVID-19. So Ibu Wayan is the executive director of the survey meter that has been working together with us in conducting the survey, and she will be presenting the method of the study and some of the results. The floor is yours, Bu Wayan.
Thank you, Pak Dinar. So we're using the data mentioned by Pak Dinar for this paper. So we have 3 points of data: pre the pandemic, and then the phone survey, 2 rounds of phone survey in 2020. So for the Silani, the older persons information system data. So this data is collected together with Bappenas and Sukumeter and supported by also with UNEPA. And the phone survey is supported by area, the Bappenas, and also us at Sukumeter to implementing the study. The dependent variable will be the change depressive symptom during the pandemic condition in July 2020 compared with the pre-pandemic situation, and also the same time for the November situation compared with the pre-pandemic situation. We create the subsample based on the pre-existing health condition. Then for the covariate, we all the information mentioned by Pak Dinar in previous slide, we using that as the covariate. We working with the 2,407 older person who have this 3 points of data. We using the log segregation for the create the model. So some of the important measurement we using is the we define the mental health deterioration using the 5 items of GDS, but we excluded the reluctant to go out of the house because of it may confuse and also creating ambiguity in answering during the pandemic. So we only using the 4 symptom: helpless, bored, dissatisfaction, and weightless, and also including the total score for this paper. We define that the deterioration is when is in the pre-pandemic is the symptom is not appear, and then the symptom appear during the pandemic condition in July 2020 or and also in November 2020. For total score, if the total score during the pandemic greater than the pre-pandemic. The comorbidity score is the total of the comorbidity cases diagnosed by the health professional reported by the older person. The pre-existing condition is defined by the at least reported have problem in ADL, cognitive depression, and other disability. Here is the selected descriptive statistic of the percentage of mental health deterioration on the selected covariate. The total score in November 2020 less than those total score in July 2020. Some we saw that one of the symptom is worthlessness is the slightly increasing have increasing score in from July 2020 to November 2020. Some characteristic of the respondent associated with this condition, for example, for the sex is pomil and also for the age is the age 16 to 69 years old, and also for the who not reporting comorbidity during that period, July and November 2020. Here is the regression result. We divided the information into group. One is without pre-existing data, and another one with the pre-existing health problem. Then the other one is without pre-existing health problem. The older person who live in Yogyakarta or in Jakarta less likely have the reported less likely to have a problem related with the deterioration on health, mental health compared to their counterpart who live in the Bali province. This condition is for both condition in older person with pre-existing health problem and also without pre-existing health problem, but without pre-existing problem only in Yogyakarta. The older person with decreased income, with increased income, postpone visiting health facility during the pandemic, and also with morbidity score 1 or older, and including also with this the number of social support on the activity daily living, it look like that older person have more risk, more likely to have the mental health deterioration during the pandemic. In other hand, when the older person meet with the family or relative through the telecommunication media, social support from the post-secondary care, and including also the relaxation of the quarantine, this protecting the older person from the mental health deterioration. Pak Dinar will provide more discussion on the result and also policy implication. Pak Dinar, please.
Thank you, Ibu Wayan. So based on the findings from some of the selected variables that we think very interesting, we see that economic security is very important. It mediates the negative impacts of the pandemic on older people's mental health status. We can see from the data that Bali province that is worst hit by the crisis post the pandemic, they experience minus 12% of the economic growth. The mental health problems increased quite significantly in that area among older people. And based on our observation, it didn't only happen on the older population, but also on the working age population as well. And from the result, you can also see that those who experience income decrease also experience more probability to experience a mental health problem. The second thing that we see is that better health status and access to health and social care can improve older people's mental health. So this situation is especially important during the pandemic, COVID-19, because during the pandemic, many older people, they postpone to access healthcare, but some of them, they receive social care. But of course, not every older people are facing the same situation. Some older people, they can only postpone their regular visit to the health care facilities and probably didn't receive anything as a social care from the community. And this situation probably would bring some type of mental health problems, especially due to the self-isolation. Communication with family prevents mental health problems. However, we see some interesting result that being too dependent to family support actually has the opposite impact. So it seems like there has to be a certain level of communication and dependency between the older population and their family, their children, or other type of extended family that would make them feel more comfortable. When they are having enough communication, it seems it helps when they're facing mental health problems. But when the connection is more codependent, or they are very dependent on the family support, it would actually create more mental health problems. And it's probably due to their physical health situation as well. Maybe this is also implying that they're not very healthy physically. That's why they are also feeling more depressed. When we are using the quarantine, the social restriction index in the analysis, we see some significant impact, and this suggests that quarantine relaxation is positively associated with better mental health status. So hopefully this is also explaining that some type of social interaction, or probably when the quarantine is relaxed, they feel less worried because they feel that the outbreak is slowing down. That's probably also impacting their way of seeing their life and the world in general. So some of the policy implications that we're thinking is that maintaining economic and financial security of older people is crucial. Whether or not there is a pandemic, if we can secure the situation, economic and financial situation of the older people, that will be the best for them, and that surely impacts their mental health well-being. And this is something that needs to be researched further, but sometimes this is also very related to the economic and financial security of the family as well, because about 80% of older people in Indonesia, they live with their family and have their own family member as the caregiver. Access to social and health care, and especially during the pandemic, should be expanded to prevent depression. This is something that we would really like to suggest to the ministries that are providing some type of social or healthcare to the older people to hear, and also to try to translate this into some type of policy. Of course, being in contact will increase the possibility of getting infected by COVID-19. So probably we have to find a way how to make this possible to provide social and healthcare to the older people, prevent them to experience isolation, and maintaining their mental health. And last, we think that family members play a very unique role in this. If they are there to help, and they're there to provide some type of attention to the older people, they could be helpful and impacting the mental health positively. But when they are very dependent on the family, it seems like they are not very happy with that kind of situation. But probably that is not because of the family itself, but also because of their own condition. So this is such an interesting area to work on, how to train the family members that are providing care to the older people to be able to kind of like combine the type of the interaction that will produce the optimum mental health status for the older people. I think that will be all from our team. The writers, the authors of the paper are actually more than only us, but we are representing them now. Thank you so much, and we are looking forward to hear your input, suggestion, or questions. Thank you.
Thank you so much, Dr. Dinar and Dr. Suryastini. Your presentation, which discussed a fascinating data set, will be discussed by Dr. Vasuntara from the UNSW Business School of Sydney, Australia. Dr. Vasuntara, please.
Dr. Vasutara, you mute. Can you unmute, please?
Thank you very much, Dina, and the team in presenting this paper. It's very, very interesting and also very relevant to the time we are now. So just briefly, just to capture before my comments, the key point is that to investigate the mental health among older people during the COVID-19. This is a very interesting data set that is running. And we are looking at the comparison at 3 time points at baseline 2019. And also the phone surveys in July and in November for 2,400 people aged 60 years and older. So you use a logistic regression to look at the changes on the dichotomized mental health and deterioration based on the geriatric depression scale. So I just summarized the key points that you divide the analysis in stratify into pre-existing health conditions. So those without pre-existing health problems, social interactions reduce mental health deterioration. But for those that have pre-existing health conditions, so social support by Posindu plays an important role. And the conclusion that relaxing the social activity restriction reduce probability of depressive symptoms. So first, I have to say, as I mentioned, that it's very important study on the mental impact of COVID-19, as the evidence is still quite limited in emerging Asia. There's also important policy implications, especially on your last part, in monitoring and also possible interventions. And as we know that the current wave of COVID-19 currently is still very, very strong, and it might be here to come. So the findings suggest different approaches to social support for older persons based on their health profile. So firstly, I just mentioned that COVID-19 really not just affecting the physical part, which I think people focus on, but it's also the mental health, the comorbidities, depression, and also actually social well-being as well, because they are actually the one that most isolated, as you mentioned. We know that the studies were conducted in Bali, Jakarta, and one of the main findings is that urban residents were 2.7 to 4 times more likely to report mental health decline. And the first point I just want to check is that I think I note in the paper that there's 2,251 urban dwellers compared to the 156 rural residents. So there's a very predominantly urban, and I would imagine these are mainly in Bali and Jakarta, and a smaller subgroup in Yogyakarta. I think I just want to check. And with this, I'm wondering to which extent it has an impact on the findings because of these differences. The other things I'm also wondering is also, are there differences in the role of Posindu in rural versus urban areas, because it seems to be quite a major part of your conclusions. The two other parts that relate to the studies is that I'm wondering about the contextual factors related to COVID-19 in the communities and also in the areas that you study. How does that work compared to the rest of Indonesia, for example? I would imagine these are quite a high contracting area for the COVID. And lastly, also, I think probably looking forward in terms of adaptation and the impacts of this intermittent lockdown. So your study is looking at during that 6 months, the last year period, but I'm wondering how the social support and mechanism changes as time goes by. Now, if you have another way of, for example, what would you anticipate with the older person's adaptation and how the policy changes as well. So that's my main point, but thank you very much for your presentation.
Thank you so much, Dr. Vasuntara. Why don't we do it like this? Dr. Vasuntara, can you please first respond as briefly as possible to Veronica's comments on your paper? Thank you.
Thank you. I might just leave the share and just go to my note here. Thank you very much, Veronica, for your many interesting points. I'm just going to address very few that quite relevant to maybe way forwards. I think the first one you mentioned that Mongolia is still relatively young, and yes, that's true. But the rate of hypertension in the country is very, very starkly high for young population, and that's really, really concerning for 40% at this stage. And when people are aging like twice number within 15 years, so I think that's really a main policy of worrying and something that the country can do to prevent even before the aging, population aging happening in the 15 years for the country. So in terms of limitation of data, yes, we only have Ulaanbaatar data mainly, plus 2 rural areas close by. So that's I think something that I acknowledged in the paper that could affect how it might not be spread around throughout the Mongolia. So our main point was actually comparing between the urban and then the GER close by, which is really that's something we hypothesize that these are the groups that fall through the crack really. So they're not really out the rural area where there's primary healthcare that they can around the area, but they are also in the urban area, but not able to access, whether it's because of financial barriers and not having the money to bypass the services. So I think these are subgroups that are quite important. The two other part is that multidisciplinary infrastructure is very important. And as we know in healthy aging, the functional capacity is important, but also environment that people live and whether people can access or not. So that's why I point out the importance of transport systems. In terms of satisfaction in services, I didn't present have it in this presentation, but yes, in the paper, we do find that rural residents actually have a high satisfaction in the services. And you rightly point out that it could be probably the expectation, because when you're in the area, you see people that can access other higher services that you can't. So I think this can actually affect their satisfaction respectively. Just two last point about resources. Yes, the study was funded through our research in Australia, but it's really led by the Mongolian partner. And the visual didn't provide funding, but technical support. So the questionnaires are quite similar. The age group slightly different. So we are doing 60 plus, where the stage is 50 years plus. But other than that, I think there's potential for comparison. With the cohort data, it's always an issue with funding. At this stage, there's nothing promising at the moment. But what we have done is that we use this other capacity training as well. So the person who actually worked previously on this data is a medical student in Australia who has interest in Asia. And also because the study is actually hosted by the Mongolian National University of Medical Science, we also have master and PhD students who work on the data. So just briefly, the importance of data is not only collecting, but also using and also disseminating the data. And that's something that similarly challenges everywhere. Last point is the universal health coverage. And primary health care, yes, this is the area that I'm actually interested in, and I've worked in Thailand, Sri Lanka, and China before. I think that Mongolia has a lot of potential, challenges on geographical area, but a lot of potential in terms of really be able to bring up the system to get ready for the aging population that's coming up. And this is, as I learned from the ADB, 3 decades of partnership in the area, that there's so much that have to be done in terms of not only improving the first infrastructure, but also changing the way people access services as well, that so people feel like they can go to primary health care to go for health prevention, for example, and health promotion. And it's very encouraging to see the mHealth starting happening now and health promotion services in primary health centers. So thank you.
Yeah, thank you, Dr. Vasuntara, for the clear responses, and also to Veronica for the good comments. I just have a quick query for Dr. Vasuntara. I think one very interesting and significant finding from your analysis was that free healthcare does not necessarily translate into more equitable healthcare, right? I found that interesting. Can you just I'm sure you already did, but can you just briefly re-explain why that is the case in your analysis? Thank you.
Yes, in our analysis, really, the services might be free, but there's opportunity cost to get to the services. And I think that's really, really a big part in Mongolia. And it's very difficult for older people because yes, you have free service, but if you're not able to get to that, then people just bypassing to secondary healthcare. And now there's other expenses that they have to do. And this is a really big problem and will be a very challenging thing in Mongolia, having known that it's one of the very sparsely populated in the world. So that's just my briefing. So the financial barriers, it might be addressed, but non-financial barriers, it hasn't really been addressed.
Yeah, that makes sense because Mongolia is a very sparsely populated country with high transportation costs, high mobility costs. Yeah, thanks. So Dr. Dinar, can you also briefly respond to Dr. Vasuntara's comments? Thank you.
Yes, thank you. So Dr. Vas, thank you so much for the comments. It's very correct. Actually, of 3 provinces, Jakarta doesn't have rural area. So everyone in Jakarta will be older people living in urban setting. For Yogyakarta, we have 2 rural area and 1 urban area. And then for Bali, we have 1 urban and 1 rural. However, while we census all older people in the regions, not all of the older people have telephone when we did the phone survey. So that's why our sample for the phone survey then skewed to those living in urban area with good access of phone, and also those who are younger older people who are still able to use phone, respond to the questions, and then engage in the conversation. So I would agree with you that this is pretty biased in that sense. Regarding the policy impact of the our policy implication of the program of the study, I think this has become quite a big issue, mental health during the COVID-19 pandemic, especially for the older people. And we have started the conversation, and several days ago, the Ministry of Health has started some type of symposium talking about older people well-being during the COVID-19, including mental health. So to be honest, I wouldn't say that there has been a very significant change in the policy, other than many institutions start to change the way of their way of providing care to the older people to maintain their well-being without having to increase the risk of infection. But the conversation has started. I think that would be all from my side. Ibu Wayan, do you want to add anything?
Yeah, on the posyandu, Dr. Vas, so actually it's not different between the urban and rural area, but the posyandu program in Yogyakarta province is more developed compared with in Bali or in Jakarta. I think also that one is this why influence the why is the situation in Jogja is more protective and compared with Bali.
Just want to mention that I had a chance to go to Yogyakarta just before the COVID and visit some of Posinjo and Posinjo Lansia, and very impressive with the range of services. And so, yes, I'm glad. Thank you.
Yeah, thank you, Dr. Vasuntara, and thank you, Pak Dinar and Ibu Wayan. Just a quick question for Pak Dinar and Ibu Wayan is, this is a really fascinating database that you have built up, the impact of COVID-19 on the physical and mental health of older persons. So what I would like to know is that, do you plan to continue to build databases? Because COVID-19, as you well know, is far from over in Indonesia. I think Indonesia, along with most of Southeast Asia, was hit the hardest this year, in fact, right? Rather than last year. So do you plan to have another survey? Of course, surveys are costly and time and effort intensive, but I do want to know.
Well, not at the moment. It doesn't mean that we're not going to do that at all. But we just finished the second round a couple of months ago. So what we are trying to do is to see if the situation changes and there's a chance for us to get some support in conducting the third round, for example, for the phone survey. Of course, that is in our consideration, even though currently we don't have any survey support yet. The longitudinal study that will be sponsored by ADB will probably follow up some of the respondents from Silani as well as the phone survey. So this is probably a good way to see some of the development. And another update that I would like to provide, even though it is not directly related to your question, is that we have expanded Silani to even more villages. And we are working with Ibu Wayan as well in bringing Silani to several other locations in Indonesia. So hopefully when we have support to do, let's say, a third round of the phone survey, it would be something that cover more than 3 regions. And hopefully it will be something that is more representative. Hopefully if the situation allows, we will be able to do more than just a phone survey, but also a physical survey. And that would probably provide a even better and more valuable information.
Thank you so much, Pak Dinar. We are just right spot on in terms of time. However, the other room has been extended for 5 to 10 minutes. So I would like to open the floor to questions from the audience, if any. I mean, we do have even though I was very uptight about time management, sorry about that. We do have some time left now because the other room has been extended a little. So are there any questions from the floor, please? If not, let me ask Pichaya what we should do in terms of the technical issues involved.
Well,
yeah.
Thank you, Dr. Park. I think since we have some time, can you ask all the speakers to turn on your camera quickly so we have a group photo for speaker of session 5B? And then after that, we can just return to the plenary and wait for a couple of minutes for the others room just to join us. So in the meantime, can I ask all the speaker of section 5B to turn on your camera for a quick group photo?
Yeah, good idea, Pichaya. Thank you.
Only the speaker, please. I'm sorry, only the speaker. On my count, please. 1, 2, 3, smile. We do one more shot just in case. 1, 2, 3, smile. Well, thank you very much, everyone. And we have a couple of minutes for your break, and you can just leave the room and go back to the main room. And then after that, we will have the closing session. So thank you very much and see you shortly.
Thank you very much, Pichaya, and many
Thank
thanks
you very
also to
much.
all the speakers and the discussants. Thank you.
Thank
Thank you,
you.
Brandon. Thank you, Dr. Flas. Thank you, Buaya.
Thank you very much. Thank you, Dina.
Thank you.